In more normal times, this is the talk where you would all file into the lunchroom and hear the wonderful talk. Now, hopefully you can grab a sandwich and sit at your desk and listen to Dr. Joel Katz, who is an associate professor of medicine at Harvard Medical School, a physician in the Department of Infectious Disease, and the program director of the Brigham and Women's Internal Medicine Program, along with Dr. Richard Mitchell, who's a professor of pathology and professor of health sciences and technology at Harvard Medical School. This is a wonderful, thoughtful, case-based talk, and I'm sure you'll enjoy it.
Thank you very much. I am Joel Katz. I'm the internist in this pair, and Rick Mitchell, who you can see is the pathologist, and you'll notice in his picture he has a microscope behind him so that you can tell us apart. Rick and I have been working together for decades, and we've picked out 4 cases that illustrate the importance of the very close relationship and the intersection between the clinical clues available through internal medicine and the pathological insights after biopsy are done. And we, with no further ado, will launch into these cases. We have no disclosures to report. Case 1. Is a 49-year-old woman who presents with 1 month of fatigue, peripheral edema, and flu-like illness. And I would say as an internist, this is a very vague presentation. Many things can cause these symptoms. However, when you add edema in, it is almost always going to be one of 3 problems, and that is congestive heart failure, liver failure, or nephrotic syndrome. Basic laboratory studies show a hematocrit of 35%, a blood urea nitrogen of 27, a creatinine of 1.4, albumin low at 2.8, and a globulin fraction that's normal, pointing us again in that differential to the kidneys. Additional workup shows cholesterol of elevated, 440, 4+ protein on the dip. And remember that when you're dipping for protein, the way the dipsticks work is you're picking up principally albumin as the protein, and you will miss Bence-Jones proteins or immunoglobulin fractions because of the design of that test. Creatinine clearance is 90% of predicted, and urine, 24-hour urine measurement confirms 3.5 grams of albumin. And here's your first question. Patient's clinical history and laboratory findings are consistent with which diagnosis? Beautiful, great. 100%. And I'm surprised nobody said D, I'm too busy eating lunch to answer. You'll give us the when we can move on. That is the correct answer, by the way. I'm sorry, next slide. Okay, I apologize. There we go. All right, so our proposed answer here is nephrotic syndrome, which is evidenced particularly by the elevated lipids, the clinical symptoms of fluid overload, and the confirmation of urinary protein. Nephrotic syndrome is defined as heavy proteinuria, hypoalbuminemia, and peripheral edema, all of which this patient exhibited. And hyperlipidemia and thrombotic conditions are common but not required for the definition. The etiology is quite interesting, and it differs by age and to some degree by risk factors. And you can see up on board what the etiologies will be in children by percentage. In adults, the rates are different, as you can see, and we're going to talk about a few of these in more detail. There are numerous secondary causes. In fact, secondary causes are especially common in older adults. And in those, these are the conditions that you'll see the most. And I will point out this IgG4 related disease is an increasing medical and public health issue. I am an infectious disease specialist, and I often see this in conjunction with subacute bacterial endocarditis or with a number of the viral infections, particularly hepatitis B, C, and HIV. These are neoplastic causes, which are not uncommon, particularly multiple myeloma. And certain toxins can predispose to secondary nephrotic syndrome. Membranous GN, which is an important category in adults, is largely idiopathic despite exhaustive looking for the cause. And of the ones that are diagnosed, lupus is probably the most common underlying cause, and occasionally but rarely drug associated. Minimal change is more common in children than it is in adults, but it can occur at any age, and the importance of identifying is that it is steroid responsive. FSGS has two categories, the primary and the secondary causes, and this is where we see in relationship to the viral illnesses, HIV very commonly in the population I see, and hepatitis C in particular. And I'm going to hand it off to my colleague, Dr. Mitchell.
Very good. Thank you, Joel. And welcome from pathology. I am a cardiovascular pathologist, but I have some facility in all these other things. The goal here is not to turn you into pathologists. The goal here is to give you a fighting chance when you see an image that shows up on a board exam going forward, and also to give you a way of thinking about the pathology when you do hopefully interact with your pathology colleagues. I'm trying to run my mouse. I'm not being very able to.
Up at the top, you gotta take mouse control.
Okay, I have to take mouse control. I'm sorry. There we go. Got it. All right, so thank you. So when you are looking at kidney, which is what this is all about, and you get a biopsy given that particular history, you should be looking only at the glomerulus. We're looking at filtration as the kind of major modality to get us into the increased proteinuria that's in the urine. The cellularity of the glomerulus is going to be important. We're going to want to look at the basement membrane. We will want to look at cellular architecture, and this is all going to be based on electron microscopic appearance. And finally, we will do some additional evaluation based on the immunofluorescence. So those are the things you want to pay attention to. And mainly, it's all about the glomerulus, because that's where the filtration starts. The normal glomerulus is shown here on the left. So we have a number of cells in here. We're going to ignore the tubules completely. In here, we will have endothelial cells that are lining the capillary loops. We're going to have epithelial cells, which are sitting on the outside of the capillary loops. And then we're going to have mesangial cells. And those are the three cellular components that we see here marked by the nuclei. Being able to tell them apart at this point, not too important, but you do want to look at how delicate and thin-walled the capillary loops are. And you want to look at the general cellularity, the number of nuclei that you see within here. On the right-hand side is a very good example, pretty much at the same magnification, for membranous glomerulonephritis. And what we're looking at is a very thickened basement membrane. Hence the name, it's actually a well-named entity. So we're seeing increased deposition of protein, usually immunoglobulin and or complement, but a variety of other proteins diffusely throughout the basement membrane. By electron microscopy, this is what it looks like. So either the H and E appearance that I showed you previously, or now the EM, would be fair game should you see this on a board exam. So this is the endothelial cell. You can see the fenestration. So this is a fenestrated, meaning that there are holes in the endothelium. It sits on top of a very thin, delicate basement membrane. And then we have the foot processes of the podocytes of the epithelial cells on the other side. That's normal. On this side, again, you see our endothelium. You can see the fenestrated endothelial plasma membrane throughout here. The podocytes are over here, but the basement membrane is diffusely thickened with an electron-dense deposit. And these are the variety of proteins that have accumulated within there. And we talked about the various entities. Most of the time when we see it, we don't know exactly what the protein is. 85% of these are idiopathic, but this is a very characteristic appearance for the membranous GN. I'm not showing you now, this is a different entity. This is minimal change disease. I'm not showing you the H&E because the H&E is not any different than completely normal. It looks like a normal glomerulus, hence the name minimal change disease, also called lipoid nephrosis. So we're back to EM, and here's our normal endothelial cell, fenestrations, normal, thin-walled, delicate basement membrane, and then the foot processes of the podocytes on the other side of the basement membrane. Here in minimal change disease, although the H&E doesn't look like much, the electron microscopy is classic, very characteristic. And the foot processes, instead of being these nice interdigitating podocytes, are big, flat, almost slug-like epithelial cells. The reason is that because of either cytokines or a variety of other injuries, we have lost the polyanion that allows us to have the normal architecture that we see in the normal glomerular podocyte. And now we have lost a lot of the normal filtration apparatus, which happens at the slit-like opening between the interdigitating podocytes. And here, protein is just oozing through into the urinary space with aplomb. So that's minimal change disease, and we're seeing foot process fusion. The third of the very most common entities associated with nephrotic syndrome. So we have had membranous glomerulonephritis, minimal change, and now we're looking at focal and segmental glomerulosclerosis, or FSGS. It's called focal because only some glomeruli show the change, and segmental because only parts of the glomerulus are abnormal. So this part of the glomerulus, actually pretty normal. Nice, thin capillary walls, the number of cells look pretty good, but what we have in here is an area of scarring. This can be due to vasculitis. It could be any of the things that Dr. Katz previously showed you. But what we're looking for is this focal scarring within the glomerulus so that we kind of get a fibrotic occlusion of part of it. And then we can look at EM, and that will give us a hint for some of the other things that may be causing this. It is a fairly long differential, but if on EM we see intraepithelial tubular reticular bodies, so this is within the epithelium, here's our basement membrane, this would be the endothelial cells. This tubular reticular body is very suggestive of either HIV or heroin in terms of the etiologies for that, and we can comment. Okay, so we've talked about, and one last entity that we need to also emphasize, because this is classic, nothing else looks like it. So we have our glomerulus, and we have this nodules of pink amorphous material that are in the glomerular capillary tufts. This is formed of protein, including albumin, fibrinogen, fibrin. There are lipids that are in here as well. This is very characteristic, as the title said, for diabetic glomerulopathy, and these are called Kimmel-Still-Wilson nodules. And so if you see an H&E that looks like this with the nodules, this is absolutely classic and pathognomonic for diabetic renal disease, which can also cause a nephrotic syndrome. Okay, so we talked very quickly about nephrotic syndrome and gave you the 3 to 4 most common entities that you will encounter. Talk briefly about nephritic syndrome, which is hypertension, hematuria, and proteinuria. And the etiologies for these include vasculitic changes or autoimmune changes, post-infectious changes, and idiopathic always enters into the differential. I want to show this because there are a couple very characteristic lesions that you should have in your hip pocket should they show up on the boards. So we haven't looked previously. I mentioned that immunofluorescence is part of our workup. If we had a membranous glomerulonephritis, remember we had those electron-dense deposits in the basement membrane. If we look for immunoglobulin complement, we get these globby depositions that kind of mark in kind of irregular, spotty deposition all along the basement membrane. And that's the typical immunofluorescent pattern that we would see for a membranous GN. One of the entities that cause nephritic syndrome, not nephrotic syndrome, but nephritic syndrome is Goodpasture disease with monoclonal or antibodies directed against basement membrane components. When we do the immunofluorescence on this, we will see a characteristic H&E pattern with a crescentic glomerulonephritis, so a proliferation of the epithelial cells. But the immunofluorescence is the thing that is most characteristic, and it's a diffuse, uniform staining of the capillary basement membrane all throughout. So it's not globular like we have over here, it's diffuse and uniform. And that is nothing else but Goodpasture disease due to the uniform deposition of the antibodies directed against the basement membrane. The other one that's very characteristic and classic is a post-infectious glomerulonephritis. So a post-streptococcal glomerulonephritis, for example. And what we will see, this is the glomerulus, believe it or not, it's very, very hypercellular. Lots and lots of cells in there. It almost doesn't look like a glomerulus. It almost looks abscess-like because there are so many neutrophils and other mononuclear inflammatory cells. They've been recruited by the deposition of immune complexes coming from, say, our post-streptococcal disease. And when we look by EM, this is the classic appearance of the subepithelial hump. So these are complexes of antibody antigen that derive from our original streptococcal infection. And that is giving rise, these immune complexes in here are giving rise to the recruitment of Fc receptor-bearing cells such as neutrophils and monocyte macrophages. So two very classic lesions associated with nephritic syndrome. And I'll turn it back over to Joel.
I'm unmuted. How do I get the key back? It says viewing, view options. Here we go. Press control. Okay. All right, very good. Thank you, Dr. Mitchell. Our second case that highlights the link between clinical and pathological examination is that of a 34-year-old man with a history of obesity, BMI 39, alcohol use, 4 beers per week, and occasional acetaminophen use, who presents with 3 to 4 months of fatigue. And I would just say my clinical point here is that fatigue is a common symptom, and oftentimes the answer is going to be in your epidemiologic and your historical clues. Initial laboratory observation confirms a transaminitis, as documented there, a mild elevation in the alkaline phosphatase, and normal bilirubin, which I think is very helpful. And importantly, synthetic function is normal with a 1.0 INR, and albumin is within the low end, just below the normal limits. Clinical pearl, if you will, is there's a poor correlation between transaminitis and the extent of liver damage. And in fact, in the most severe cases of liver damage, there is no transaminitis at all. The ratio can be helpful, particularly with AST over ALT, much higher ratio in certain conditions, in particular in alcohol toxicity. Recommended workup for transaminitis includes the viral hepatitis serologies, the autoimmune hepatitis serologies, various toxin levels, looking for evidence of iron overload or genetic disorders such as Wilson's, alpha-1 antitrypsin, and then mechanical obstruction that can be seen on an abdominal ultrasound. Dr. Mitchell?
Thank you, Dr. Katz. So once you have done your laboratory evaluation, of course, you're going to now send them off to interventional radiology or somebody else who's going to do a liver biopsy for you. So let's think through how you're going to approach seeing the liver biopsy when this appears on your board exam. So we're going to look at the overall liver architecture. Overall liver architecture, we're going to look at whether or not there's portal inflammation and how much it extends outside of the portal tract. We're going to see whether or not there is hepatocyte necrosis, and we're going to look for particular evidence of inclusions. So those are the things that this gives you a fighting chance when you see this histology. So the typical liver architecture is shown here on the left. This is completely normal architecture. You have cords of hepatocytes. They're They are actually arrayed from the portal triad out to the central vein, but we don't always get to see them as nice rays. We tend to see them as these kind of sinuous cords of cells. And in between is going to be the vasculature. This is the sinusoids where blood is flowing. They're going to be inflammatory cells, etc. But there should be this general organization of cord, sinusoid, cord, sinusoid. On the other hand, when we have injury, hepatitis, in the liver, we lose this beautiful architecture, and we see kind of disarray and a death and dying. So we have apoptotic bodies, we will have inflammatory cells, and importantly, we have lost the normal sinusoid and cord architecture. So at a very low powered view, we can say, yeah, there is disarray and death. Unfortunately, that pattern doesn't really get you too far because the etiologies can be toxic, they can be ischemic, they can be infectious, or they can be autoimmune. However, there are ways that you can sort these out. So, for example, in terms of looking at inclusions, this is hepatitis again. It's got that disarray. I can't find good sinusoids and cords. I have inflammatory cells. But within the hepatocytes, I'm seeing these pinkish aggregates. This turns out to be intracellular cytokeratin that happens in the setting of alcohol, recurrent alcohol abuse. And this is called Mallory's alcoholic hyaline. So that inclusion will lead us to suggest that the etiology for the hepatitis would be alcoholic. On the other hand, in say chronic persistent hepatitis or hepatitis carriers, or we will see inclusions that include a ground glass cytoplasm or sanded nuclei. These actually represent little viral factories, if you will, within the hepatocytes, massively expanding the cytoplasm with the organisms as they proliferate, and they are actually redistributing the cytochromatin or the chromatin within the nucleus to get that sanded nucleus appearance. So we can suggest hepatitis B based on that appearance. Non-alcoholic steatohepatitis is an increasing reason for patients to present with elevated transaminases. And actually, in about 70% of obese individuals, there will be some degree of non-alcoholic fatty liver disease. In this particular case, this is non-alcoholic steatohepatitis, or NASH. This will occur in up to 20 to 30% of obese individuals. What we see is steatosis. We see the accumulation of fat lobules. These are actually triglycerides within hepatocytes. And they are very characteristic of either fatty liver disease, but this is also characteristic of other toxic exposures, including alcohol. And then we see inflammation scattered throughout. So this pattern of fat and inflammation, and again, we have total disarray of our normal architecture in here, will get us to steatohepatitis. And if the patient says, nope, never had a drop of liquor in my life, then we're into the alcoholic NASH category, and also clearly there will be some obesity that will be apparent. Okay, so the other thing that you're frequently getting biopsies for is to look at whether there's a chronic persistent hepatitis or a chronic active hepatitis. And I will say that these days the hepatologists have actually divided this into hepatitis with minimal activity, that's the chronic persistent hepatitis, or active hepatitis with mild, moderate, or severe activity. I'm going to use the chronic persistent and chronic active hepatitis descriptors as I go through this. So here's our low power view of the liver. Again, we see our cords and sinuses. This is the portal triad. And in the portal triad, we have an hepatic artery, we have a portal vein, and we have bile duct epithelium. And then we have a fibrous connective tissue plate that contains all of those, surrounded by all of the liver parenchyma. And we're going to care about inflammation in this area and whether it stays confined to this area or goes outside of that area. So basically, in chronic persistent hepatitis, we see at low power on this liver biopsy, we see areas of inflammation that are more or less confined just to the area of the portal triad, doesn't extend beyond that. In comparison, chronic active hepatitis, and this would be active hepatitis with severe activity, we see inflammation, the blue cells, extending from portal triad into central veins and from portal triad into portal triad. And so all the blue inflammation is now a mononuclear inflammatory cell infiltrate that's extended beyond the portal triad, and it's associated with fibrosis. So we are well on our way. In fact, we are already into cirrhosis in this setting. So this would be the difference between a chronic persistent and a chronic active hepatitis. This is just a gross view of what cirrhosis looks like in a liver. The liver is typically shrunken, and we have this very nodular appearance. The nodular appearance actually becomes quite apparent when we look at the histology. This is a trichrome stain, so it's not the typical H&E stain, but it shows up fibrosis as blue. So all of this blue material in here is collagen, is scar, and we have dense bridging fibrosis from portal triad to portal triad and from central vein to central vein. And captured within that are these poor residual nodules of liver that's trying valiantly to regenerate and is not able to do so because of all the fibrosis. That fibrosis is the area in between the nodules that you see here on the gross. And clearly there's going to be disrupted normal movement of metabolites through the liver. There's going to be abnormal bilirubin secretion. There are going to be a number of abnormal metabolic parameters that we're going to see. When we see cirrhosis, hepatitis C is probably, along with non-alcoholic fatty liver disease, the two most common entities in the United States, followed not too far behind by alcoholic liver disease, and then other entities. And hemochromatosis constitutes perhaps 5%. Dr. Katz.
We're going to go into case 3, and before I do, I just want to highlight a couple points that Dr. Mitchell made there. The one point that comes up on the boards, which is I know why a lot of you are taking this course, is how to differentiate acute versus chronic active hepatitis B, and the board's answer there is your core IgM positive. So that's the test that'll come up that will differentiate acute hepatitis B from where it's positive from a chronic active hepatitis B where it's negative. All right, continuing on. Our third case, highlighting the overlap between internal medicine and pathology, relates to a 45-year-old man who presents with a month of a blistering disease. And what I would say in blistering disease is when I see them, the history is critically important. What other illnesses they may or may not have, the location of the blister, what part of the dermis it's in, shallow or deep, and then the characteristics of the blister itself. The differential includes pemphigus vulgaris, which is a very superficial, and on physical examination, as you rub the edge of the lesion, it will peel off, it will rupture spontaneously. And the histologic findings will be reviewed by Dr. Mitchell. Bullous pemphigoid, similar sounding but unrelated, intact superficial dermis, spares the mucous membranes. And then dermatitis herpetiformis, which is an important one not to forget, associated with gluten sensitivity. Often in the locations listed there, symmetric, back, knees, elbow, in my experience behind the neck on the hairline as well, with characteristic pathologic findings. And then lupus as another immune cause, primarily noted in sun-exposed areas such as the chest, neck, forehead, and forearms. And before I hand off to Dr. Mitchell here, which while he's taking control, just say that there are many other blistering diseases that tend to be contact dermatitis as well.
Thank you very much. So in terms of our approach to these particular issues, we're going to care where the cleft is, so at what level within the skin the cleft is. We're going to care whether or not there's inflammation and how much of it and what kind, and we're going to look at the immunofluorescent pattern. So that's what we're going to do. So pemphigus vulgaris is an example here shown, and it will involve the mucous membranes, whereas the others will not. And importantly, the cleft is between the basal layer and the rest of the epidermis. So this is the rest of the stratified squamous keratinizing epithelium. You will have this layer of tombstones. That's what it's been likened too. So if you think about tombstones as being vulgar, that'll help you remember pemphigus vulgaris. So it's a suprabasilar cleft. And then the individual cells are falling apart. The reason they're falling apart is that the antibody is directed against the desmosomal component, and it's activating the keratinocytes in here to make a urokinase-like plasminogen activator that activates a protease that degrades the connection between cells. And so when we do the immunofluorescence pattern, we see this reticular pattern outlining each one of our keratinocytes throughout. So it's a very characteristic appearance. Notably, not much inflammation. This is all driven by antibody driving the activation of a protease. So that's pemphigus vulgaris. Bullous pemphigoid has that gross appearance. The cleft is quite different. So it's between the basement membrane and the rest of the epidermis. So we don't have that layer of tombstones along in between. And the inflammation, again, is rather sparse. The staining, because that's where the antibodies are binding, are to a component of the basement membrane. And so we get this linear dermo-epidermal junction staining of immunoglobulin and complement. And again, it's not because of cells that are causing the autoimmune disease here, but because of the antibodies that are activating proteases that are causing cleavage of the adhesion molecules that normally hold the skin on. Dermatitis herpetiformis, again, as Dr. Katz said, associated with gluten-sensitive enteropathy or celiac disease, typically on extensor surfaces, tends to be symmetric on the back. It's a good example up around the hairline as well. And what we're seeing is, again, a subepithelial blister. So basement membrane would be in here, and we have the entire epidermis above it. But we do have much more inflammation. They tend to be smaller blisters, and we have a lot of acute and chronic inflammation. So the subepithelial blister, and characteristically, instead of a linear deposition that we saw with bullous pemphigoid, we see the granular deposition, and it's IgA. It's not an IgG, which we had seen in our previous two cases. Lupus is not classically blistering, but it's one that you should be familiar with, and it's usually on sun-exposed skin. And histologically, we see a lot of inflammation. It tends to be at the dermo-epidermal junction, so it's much, much more than what we saw previously in the dermatitis herpetiformis, and it tends to go around hair follicles and sweat glands, etc. And the histology is a granular IgG deposition, so not the IgA that we saw in dermatitis herpetiformis, but IgG. And Joel, back to you.
Excellent. Thank you very much. Case 4 is a clinical syndrome that is perhaps the most common of all the ones we presented and unites the importance of a careful history and exam with visual inspection. And that is of a 29-year-old woman in this case who volunteers to donate blood and is found to have a hematocrit of 24%. Clinically, when we think about this, the history is critical. Is this a genetic acquired abnormality, such as sickle cell disease? Is this a issue of bleeding or sequestration, such as gastrointestinal bleed, or in young women, menorrhagia? Or is this an immune destruction of immune or other non-immune destruction of red cells? The reticulocyte can be extremely helpful. The MCV can be extremely helpful. But the most important aspect is to look at the smear. And I will hand it back to Dr. Mitchell.
Thank you. So in terms of going after what's going on the peripheral smear, you want to look at red cell size, shape, and central pallor. And you do have an internal control for the size of the red cells. They should be about the size of a lymphocyte nucleus, so 7 to 8 microns in cross-sectional diameter. You want to look at the number of white cells, their granularity, and the nuclear segmentation. Make sure that you don't forget about the platelets and get a sense of the number and size. And then when we're talking about anemia, we break it down into very basically hypochromic, megaloblastic, or hemolytic. So the first one here's our normal smear. Here's our normal lymphocyte for an internal control. We do have platelets everywhere, and we have a normal area of central pallor, and the size of this is about the size of that nucleus. So we're good. On this one, it's a hypochromic anemia. So we have very remarkable anisocytosis, so changes in size between big cells and little cells, but there are also a lot of poikilocytosis, a lot of variability in shape overall. Platelets are still there, don't have a lymphocyte on here for comparison, but basically there's an increased central pallor that we can appreciate in many of these cells, so we're not making enough hemoglobin. Etiologies for this, you can tell me as well as I can tell you: blood loss, malabsorption, iron, for example, or an increased requirement. Impaired heme synthesis has a couple characteristics looks where you get that right now with sideroblastic anemia. It can be hereditary, idiopathic, or lead or alcohol can lead to that. Sideroblastic anemia is going to be seen on bone marrow biopsy. So this is a bone marrow biopsy, iron stain, and we're going to see the accumulation of iron-encrusted mitochondria in early erythroid forms. They're so-called ring sideroblasts. So that's what we're looking for. And on peripheral smears, in cases where we're not making adequate hemoglobin, we will often see basophilic stippling. This classic appearance, so these are actually iron-encrusted ribosomes, for the most part, maybe some small mitochondrial remnants. Typically, this is associated classically with a plumism, with lead toxicity, but in fact, it just represents inadequate heme synthesis, and there are many causes for that. So hypochromic anemia, you can have altered iron metabolism. So anemia of chronic inflammation, where you have increased hepcidin levels and you now will not release iron from macrophages into newly synthesized red cells. You can have impaired globin synthesis, so the alpha or beta thalassemias. And the appearance here on beta thalassemia just looks like a hypochromic anemia with anisocytosis, changes in shape, and also in size, and changes in shape with central pallor. Post-splenectomy, though, we will see a lot of nucleated red cells, so you can kind of a hint that this is after splenectomy, and you'll see very large platelets. Into the megaloblastic anemia, I'm just going to show you one. Any white cell with greater than 6 nuclear lobes is indicative of a megaloblastic anemia, so B12 or folate deficiency. 5% with greater than 5 lobations, and a majority with greater than 4 lobations are all indicators of that. You also tend to get rounded cells, macroovalocytes, so are slightly larger than they should be. In hemolytic anemia, the third category, you see fragmentation, importantly, fragmentation schistocytes of the red blood cells. Again, we have our white cells, we have our platelets, everything else is fine. This is mechanical, so this could be, for example, someone who had an aortic valve replacement now has a paravalvular leak and a jet that is causing fragmentation due to the jet lesion. Importantly, this is where you want to be sure that you're also looking for the other cell types that are present. In TTP or DIC, again, you would clearly get schistocytes and fragmentation. This would give you a hemolytic anemia picture. But what's missing on this slide are there no platelets. So make sure that you're also looking for the platelets in terms of giving you an etiology. You can have genetic defects, so insufficient spectrin will give you rounded red cells, no central pallor, and these are going to be very stiff and prone to fragmentation. And then you can have elliptocytosis, which is defective in spectrin tetramization, and you get these stiff elliptical red cells, which are also going to be prone to rupture and going through capillaries. Sickle cell disease, a classic example of that. This is where we have the 6th position of the beta chain replaced from glutamic acid to a valine, which gives a polymerization of the hemoglobin whenever it gets deoxygenated, giving you deformation of the cells. And again, going through the capillary vasculature, we're going to get fragmentation. An infectious form of hemolytic anemia would be both babesiosis or malaria. The difference between these is that in Babesia, we will see single ring forms or very small numbers of ring forms, which are very small. We typically see many more larger ring forms that occur in malaria, and we will see the formation of hemozoin as we get the metabolism by the malaria parasite within the red cells. One final entity that would give us an anemia, not necessarily hemolytic, metachoblastic, or hypochromic, but because we are replacing the normal erythroid elements in the marrow, is acute myelogenous leukemia. And I just wanted to show that here because it has a very characteristic appearance on peripheral smears where you see this aggregation of eosinophilic granules of lysosomes forming our rods. And you can say then this is an M2, M3, or M4 acute myelogenous leukemia as another cause of anemia. So take-home points for us is that history and physical exam clearly suggest a differential, but then and laboratory tests will refine your list. But then a biopsy or a smear is going to be very, very important in terms of saying exactly what you're dealing with. And form follows function. So if you think about what you are looking at, glomerulus or blisters, or in terms of the red cell morphology, you can kind of understand what the pathology is. And pathologists can be amusing. So we have a couple board style questions.
We're actually gonna unfortunately have to stop right now because the time is up. I want to remind people that the questions are in your syllabus, and I really am sorry for interrupting this wonderful talk, but most of our morning speakers are back, so we can do some questions and answers as well. So there are also a few extra cases in your syllabus to review on your own, and I know you're going to find them really interesting. So special thanks to Rich and to Joel for this wonderful talk and awesome pictures.